So Dr. Girish, every so often as you see this children with cleft lips and some facial deformities and things, so that what's new, what's happening with facial reconstruction? How are you involved in this?
Yeah, I'm passionate about corrective surgeries for facial deformities. I think in India, with a huge population of 1.4 billion, we have huge number of people with cleft lip and palate. Nearly 1 in 800 patients who are born, 1 in 800 births, sorry, you do get clefts. And similarly, 1 in 1,000 is basically people with, facial deformities. And facial deformities, you can have so many kind of problems. You can have jaws which are underdeveloped or overdeveloped. It would be the lower jaw which is further forward like this, it is prognathism, or very much further back, that is retrognathism. And then you have the facial asymmetry. So you have one part of the face which has grown better or the other side is undergrown. So that kind of deformities are very, very common in India. And today, it's pretty easy to do these kind of corrective surgeries. With the technology which has changed, with the kind of training which has been imparted to the surgeons, we are doing in par with anywhere in the world, I would say.
So when you say facial deformities, how do you divide them? It's like from the forehead up to the nose, or nose to jaw, upper jaw, lower jaw? How do you divide them?
We divide the face into thirds, I would say. The upper third is just above the eye, including, the forehead, and that is where we work very closely with the neurosurgeons. When you have few skull bones, which is called craniosynostosis, and you see the kind of deformities which are happening there. So many a times the eyeball is protruding, exophthalmos and things like that because of the underdevelopment here. And that's where I work very closely with your neurosurgical colleagues at Demands and other good neurosurgeons. So we have been very, very closely working there. The most common ones which we see more common is basically the middle third and the lower third. That's basically the upper jaw. And if it is overdeveloped, the upper jaw, when the patient smiles, when somebody smiles, you see too much of teeth and gums. It's called as vertical maxillary excess or gummy smile, we call that as. Or the lower jaw, where it is slightly more protruding or, underdeveloped. Or sometimes the nose also is twisted. So you can see the kind of entire change. The whole face is completely deviated. So that is the facial asymmetries which we see. So that is how we divide it into different. And there's a lot of overlap of, doing this kind of things. Yes.
So how do you proceed? So let me put it this way. So is it more common? I think so. I think it's more common in children. That's when all these things are picked up, isn't it?
Correct.
So they're still very young and tender, and they're infants probably.
Yeah, lip and palate, when there is a cleft lip and palate, that is as soon as, you wait for 9 months for a delivery to happen, and the parents are shocked to see that there is it's a traumatic experience for anybody. But today, we can make it in such a way that you can completely treat it in such a way that you can't even make out that there has been a surgery which has been done. And the speech also can be fantastic. So that is something which we are working with, a multidisciplinary approach. And that's where for a lip and palate you need to do very early at life treatment. So generally we do the lip between 2 months to about 6 months, depending on the weight of the baby and how the growth is and things like that. Palate usually by about a year, 9 months to about 1.5 years. So that is where we do that. But then you'll have to wait for many times the growth of the child to complete, right? So there is a continuous process. These kids need to be monitored regularly to see how the development happens. And there can be certain appliances which can be put in, which can help in better growth of the child.
So molding, is it?
The molding can also be done, yes. So there are lots of devices with which you can. How much that can help is questionable, but still many a times we put these appliances, functional appliances, what we call. So for example, when you have a lip which is very wide, cleft lip, you put something called as a nasoalveolar molding. So we can actually put a simple device which the child, the baby, the infant can wear, and that brings the split lip and the alveolus, that's the upper jaw, inside. And it's closer and much easier to operate. Similarly, you can put certain devices when the child is growing, 8 to 10 years of age, to see to that the jaw expands, especially the palate can be expanded very easily because there is a suture in the middle. So these are things which we do. And then you have the definitive surgery which we do when the growth is almost complete. Today children grow very rapidly, I would say. Post adolescence, we are talking of about 13 to 16 years of age, we can do the definitive surgeries.
So obviously cleft lip, cleft palate, you can pick it up immediately, but the facial asymmetry or the facial deformities itself probably could enhance itself or expose itself as the child starts growing, maybe 8 years, 10 years and things like that. So when is it that you pick up, yes, there is a facial deformity in this?
Very early again in life, generally around 9 to 10 years of age when you see, and that's when they become conscious also. You can see a sudden change in the child's psyche also, I would say. You know, they probably in school, somebody would have commented on that, or somebody in the family would have commented, and that's when parents bring the child to us. And we look at it, and then many a times we keep it under observation, maybe some baseline measurements we would do, and investigations we do. Because sometimes you can get what is called as the jaw joint. The condyle can actually be undergrowing or overgrowing. So there are devices with which we can actually help in correcting that also at that point of time. So these are things which are brought to us early childhood, I would say. So anywhere from 8 to 12 is when we do. And that's the time even when braces are actually looked at. So we work very commonly with our orthodontists and see if the teeth position can be corrected, the jaw can be slightly expanded, and that's where we start off from there. But these children are kept for long-term follow-ups so that we can intervene early.
When do you intervene there?
Unless there is a huge psychological or a functional problem. Now, if let's say a jaw is very much underdeveloped, right? There's a syndrome called Parry-Robin syndrome, where the lower jaw is so much further back, the tongue falls back. So that makes it difficult for the infant to breathe. They stop breathing. So that is when we intervene very early in childhood itself. We make simple cuts and put a device which is called as a distractor and bring the lower jaw forward so that tongue is in the right position and the breathing space at the very back of the throat is actually restored. So for a functional reason, we may have to intervene very early. But otherwise, it's more when the growth is complete, right? Or if the child has got major psychological issues, then we may have to intervene a bit early. But generally from 12 to 15 is what we intervene.
And how often is it the reason is purely cosmetic? Or how often is it the reason is functional as well?
Good question. Difficult to say because there is a big overlap between the two. When you have a growth of the face which is not like what has to happen according to the norms, there is a bit of facial asymmetry. There is a bit of facial dysmorphism, what we call. So the problem is the child doesn't look normal, and it is kind of, you know, taunted in the school, and this is where, or from the peers and family members, and that is where professional help comes in, and that is where I think we need to, you know, intervene early. So that is something which we need to look at.
So what are these definitive surgeries? What are the options?
It can be in the upper jaw, it can be in the lower jaw, most common. I'm talking when we have jaws which are overgrown or undergrown, that is called as orthognathic surgery, or sometimes we do both the jaws. So let us say a normal jaw, if you look at it, the normal upper teeth, the upper teeth is actually in front of the lower teeth, and that overlap is only about 2 to 3 millimeters. Sometimes the thing is so much more, about half a centimeter or 1 centimeter. So the discrepancy is huge. So there is speech problems, there is chewing problems, and the facial appearance problems. These are the 3 main reasons why we would go in. So we have definitive treatments for that. The lower jaw, when we are dealing with it, we make some cuts in the back of the jaw, again done from inside the mouth itself. So we split the jaw in such a way that we can slide the lower jaw forward or take it back or rotate it this way, that way. So that is called as a sagittal split osteotomy, which is a very, very tricky operation because the nerve traverses through the bone.
Yes.
So the skill of the surgeon is in such a way that he has to preserve that nerve without damaging the nerve. He has to split the jaw, right? And it splits beautifully. It's like, you know, you're just two bones which are, two cortices which are there, that needs to be separated out. So in a calculated way, we do a fracture of the jaw. And once that has been split, then we bring it into the new position and we fix it with a tiny plate and screw. So the jaw is in the right position. Similarly, the upper jaw also, just below the nose, we make a cut and we bring the jaw completely down. It's still hinged on the palate. And then we can move the jaw, we can take it up, we can bring it down. Sometimes when we bring it down, we put a graft, so we can actually increase the height of the face. So today, face transformation can be done in a very big way. And very predictable this is, because as long as the vascularity is taken care of, the key is the bone has to be viable, and for that, the blood supply has to be right. If there is a problem, then you are in a major mess. So it is very, very important that we do the surgery very carefully.
And did I hear it right? So you're going to do it all submucosal or inside the oral?
Everything is done from
outside
absolutely. Majority of the times, these orthognathic surgeries, which are facial deformity corrective surgeries, can be done very carefully from inside the mouth. So there is absolutely, when people come to us, and they say, hey, did you undergo a surgery? It's just that the jaw is completely transformed. So you can't even see a mark on the face.
Very nice. So these are recent advances, or you've been always trained like this to do scarless?
No, see, when I was training, let's say about nearly 40 years, 35, 40 years back, these were textbook surgeries for us, to be honest.
Just read
we
about
would read
it.
about it and somewhere it's being done, that's it. But luckily we all went abroad, and a bunch of us in our maxillofacial surgery, we went outside the country, and some of them trained here itself, and then we came back and trained a lot of people. We started doing these kind of things in late 90s, I would say, mid and late 90s, and then it started, a boom happened then. So we've been doing this as a routine surgery today.
Very nice. And how are the outcomes functionally? So cosmetically, you said they look very nice. What about functionally?
The biggest problem is when you give, let's say something, when the teeth meet at the back, right? When they meet, all the teeth are supposed to basically meet properly. So there is a gap, let's say, a huge gap. Only the back teeth are biting and you're meeting there. So there is a big gap in the front. So if you give somebody a sandwich, they can't bite into that, right? It's a major functional problem. And there is a lot of lisping. The speech is not right, right? And even when there is somebody who has got a jaw which is underdeveloped or overdeveloped, in such kind of cases, again, the bite is not good. So they're not able to eat properly. They would take hours together to chew a normal food, which was done in 10-15 minutes time. So in such kind of cases, the transformation is not just aesthetic, but functional. Game changer, I would say. Beautiful results. Suddenly they're able to eat everything, their speech becomes normal, and that's something which is very, very rewarding.
And how common is this in your practice?
Oh, almost every other day I do this kind of surgery, so it's very, very common. But again, we work very, very closely with our orthodontic colleagues. They're the braces specialists. What happens is when you move the teeth, right, or move the jaws basically, some of the teeth will not meet properly. So the fine tuning has to be done to get the bite right, to get the proper function right. Not only a surgeon brings the jaws in the new position, but an orthodontist will actually get the teeth into the right position. So we work it in a combined
alignment takes some more time, I suppose.
So that would be probably about a year and a half, which the orthodontist would do. Typically what we do is we start off with orthodontic treatment to align the teeth, get the level of the arches right, whatever spacing and things like that is there, just to correct the position of the teeth first to the jaw which is abnormal, right? And then we do the surgery. So we get the jaws in the right position, and once the jaws are in the right position, then the teeth do not meet correctly. 80% would meet. So the fine tuning has to be done by the orthodontist, and he will bring that interdigitation, what we call, and that gives the best outcome for our patients.
Okay. So this is not a one-time visit treatment. It's going to be a process.
And not only that, we also will have to take into consideration the growth. If we do it very early, what happens is there is a catch-up growth. So we might have taken the jaw back. Let's say somebody is a kid. He comes to us at around 13 or 14. And if you go in early and take the jaw back, there is still a post-pubertal growth spurt. And then again the jaw might grow. So that is the reason why we need to do a lot of monitoring, and we need to assess how much is the height, how much is the growth happening, and at the end stage of the growth is when we actually do that. Some people have very late growth also, 18 years they still grow. So it depends. So that's where judgment is very important.
So these facial deformities are usually in the children, and they are exposed to their peers, and they're very sensitive to criticism. They're very conscious how they look or how the society perceives them and things. What sort of a psychological impact does this have on your patients that you noticed?
Very, very nice question. I mean, I've seen, many times kids are so introverts when they have I won't say a deformity, it is just that an underdevelopment or an overdevelopment. And there are some of them, when they smile, they show so much of their teeth, it's all protruding and things like that. They can't even have a normal smile. They always cover their faces, and they hesitate to even go out and socialize. This is something which we have seen, and one of the biggest things the parents say is they don't go out and mix with other children, things like that. It's because they're taunted. Many a times at school they're made fun of because of a growth problem. They're very hesitant to even come forward to talk about their problem. And many a times there could be even a suicidal tendency for these kids, especially the teenagers. They have this because they've been taunted so badly in school, and they go in for depression, and their outcomes in the way in which they perform in the school becomes gradually going down. So I think it's very important for parents also to identify these kind of things and bring it to help, because these can be very, very easily and very predictably corrected. I've seen in my practice, when these kids come in, they are so introvert kind of thing, and following the surgery, once their face has been transformed completely, I call these as not just face transformation, it's a life transformation, right? So you see these kids doing extraordinarily well. Suddenly they just go all out, in their studies, in the way in which they socialize, in the way their confidence comes in. There is a sparkle in their eyes. All this time they have been, subdued, or they have been going through such kind of difficult times. And you give them that kind of surgical correction, and with my orthodontist, when we work together, it's a huge difference for them. And that's probably the most rewarding kind of thing for us, I would say.
So when they come, you counsel them that hang on for some time, let this, whatever growth has to happen, let it happen. You have some future, we'll get you there.
Absolutely. In fact, there was one conference, I was surprised, I was actually going and giving a lecture. The MC was a dental student, and she had never spoken during her school days at all. And she became a good speaker, and she was the MC. And that itself, she herself said, when when primary and high school, I had never gone in, but now I have become a speaker,
Nice.
And that's something which is very, very rewarding on whom I'd operated.
That's very nice. That's very nice. Now, one more thing is, in infants, what we've seen is there's some syndromic deformities. Okay, so that would involve, say, with the forehead, the eyes, probably the ear canals, everything, the skull base itself.
Yeah.
So they can be quite significant, isn't it? How do you deal with these things?
Yes, I mean, I've been fortunate from the time I was trained in UK in the 90s that we were working very closely at Royal London with the neurosurgeons, right? Craniofacial surgery, I was introduced. In fact, even before that in Canisman Hospital, my first mentor in UK, Professor Khurshid Moose, he was probably the biggest craniofacial surgeon in UK. In Canisman, he started a craniofacial unit, and that, unfortunately, we just lost him a few months back. So I was introduced into craniofacial surgery very early in my career, I would say. And after I came back, I was very passionate to do that. And that's where, when I got an opportunity to go in and start doing an honorary job at the National Institute of Mental Health and Sciences, that's the NIMHANS, which is the National Institute for Neurosciences. I've been fortunate to work very closely with a lot of neurosurgeons. Not only in NIMHANS, but also in private. I've been, in good neurosurgeons. I have been working with Timmappa Hegde, with Dr. Madhusudan, as Dr. Satish and Dr. Murli Mohan. All of them, we have been working very, very closely with a lot of neurosurgeons. And you see these kind of very nasty upper face and skull deformities, which is now Before, it used to be just left like that, I would say. I mean, the technology today is in such a way that we can actually do a total cranial vault remodeling. We bring the whole of the forehead forward. That's the fronto-orbital advancement. These kids many a times are born in such a way that the eye is bulging out so much, and their intracranial pressure is so much that many a times you need to intervene early with the neurosurgeons. Otherwise, they could become blind too, right? So it is very important that we work very, very closely. And I started reaching out to them saying that I was trained in UK and can we do the same kind of thing in India? And luckily, they were all very warm, and then they said yes. And that's how my journey started.
Collaborative.
Absolutely. I think today, if we bring in specialities together, we bring to the table our best skills. You from neurosurgery can do some wonderful jobs. I mean, you're a lifesaver. Today, patients are alive because of the kind of work which you're doing. We can improve the facial appearances.
Quality of life, obviously.
It's the quality of life. So when we bring in together, ultimately it's the patient who gets the best benefit of that. So we have been doing a lot of things like hypertelorism, that's eyes which are splayed apart. And these syndrome patients, the Cruzen's and Apert syndrome, their face is very badly disfigured. Not only the lower part of the face is underdeveloped, but the upper part of the face, the whole vault is completely lopsided. And this is where at a very young age we start off. Multiple surgeries again we have been doing. We start with the vault remodeling, bringing the forehead forward, and then the whole of the mid third of the face, the whole of the middle part of the face and the lower jaw can be addressed as the growth happens. And to see these kind of kids living a normal life, getting back into colleges and leading that is probably the most rewarding thing I would say in my profession.
How do you decide on the timing?
Again, I think it depends on how bad the syndrome is. Many a times very, very early. And one of the things is if the intracranial pressure is going up, then my neurosurgeons say come immediately, and then we do it straight away. So it could be from 2 weeks after birth to probably 6 months is when the brain doubles in size. So early you can see that. So generally we do that from 6 months to 2 years is when we actually intervene very early.
That is quite early in terms of skull development itself. As time goes on, as they're 10 years old, 12, and again the growth spurt, would there be a change in the skull shape again when you have to re-intervene?
Many times we do have to. That's more of an aesthetic. Luckily the brain has grown by that time. So now it is all the remodeling of the skull, reshaping of the skull. And again we work very closely with the neurosurgeons and we do all that. At that point of time we take a call whether we should do the face surgery. And at times we have a technique which is called as distraction osteogenesis today, where we cut the bones and put these devices in, and that will gradually push the face forward. So we are growing it by 0.5 millimeter or 1 millimeter a day to bring the entire face forward. So that is something.
This is like the Elizarov technique, what they used to use for the
same
leg
thing.
bones, isn't it?
During the Second World War, or I think probably the First World War, when Elizarov was an orthopedic surgeon working in Siberia for limb injuries, and one limb was shot. So he just did a cut in the bone, and as the fracture is healing,
distracting.
The callus which is formed, callus is like a rubber band kind of thing. That's the soft tissue which you are expanding and allow the calcification to happen. So in a very calculated way we started. I was lucky, I went for the first distraction congress for the facial region in Paris in 1987. And when I saw that, I mean, although UK is an advanced kind of center, there wasn't much happening on Lizarov's technique, distraction osteogenesis. Luckily, my boss and me, we went to Mexico and we worked under Ortiz Monasterio, who is like, you know, one of the greatest craniofacial surgeons. After Paul Tessier, I think I would say, you know, Ortiz Monasterio. And I was lucky, I listened to Paul Tessier's, you know, all the classification of the facial clefts is on Tessier. I listened to Tessier and saw the kind of work which he had done and went and worked with Monasterio for about 3 weeks, me and my boss. We learned that and immediately started implying that in UK. So we were probably the first in UK also at the London hospital to do for hemifacial microsomias, for midfacial deformities, Lefort osteotomies. We started doing that. And the same I started doing here in Nemans and in other centers in Bangalore. So we've been doing this kind of work. Growth of the face which happens using this Liz-Rao's technique of distraction osteogenesis.
All this equipment, were they all available in India, or you had to innovate? Or
Good question. Coming from an engineering background in the family, I devised my own devices.
I was expecting that.
We tried in India. In fact, during my postgraduate time itself in Chennai, there used to be a dealer, surgical dealer. So I would sit, me and a colleague of mine, sadly he's no more, Dr. Vinod Narayan, both of us would actually get our chisels, osteotomes, hammers, all the devices, retractors, we would get it custom made. We would sit him, after the college hours, we would go and sit in his factory and give him some modifications. That's when it started. And then we also did the indigenous distractors, I would say. So I got an Indian companies to do it for us, and we would try these things off. And we adapted a few from orthopedics, right? You have these finger, distractors, which we have the small ones, that we adapted into the... So when I started doing distraction about 20 years back, it was all indigenous ones, because the imported ones were very expensive, exorbitantly expensive. We couldn't afford it. And this has to be individualistic for that patient. We can't use it again. And that is where we started developing our own distractors.
Tell me more about it. What is it that you devised, and your journey with that?
I mean, I wish I'd patented it and made some money also, but I said to the companies, you can use it, and they started marketing it, although I don't have a patent per se. But a lot of these distractors is what, we had something called as a transport distractor, where we would cut the bone and gradually distract in such a way that both sides of the jaw would bring it together and would grow the bone together. But that had its own problems and things like that. So that is why it's not very popular today. But a lot of these devices we have done, designed, modified it, and used it in our clinical practice. So that's been my journey on indigenous distractors.
Very nice, very nice. Yeah. So now that we've spoken about facial deformity correction or dysmorphic face corrections and things like that, you said we can get to as normal as possible with all these things. But can we change the entire face itself? Like a facial transplant?
Yeah, I think facial transplant is a reality today. It's already happened. First case was in Paris, where they did the first face transplant. Of course, there's a huge psychological kind of consideration which you need to think, because we, from the time we are grown, from birth to the growth phase, we see our own faces in the mirror, and we get our own identity. And then to think that you are somebody different when we take the face of somebody else who's unfortunately we have lost, maybe because of an accident or something like that. And when the face is transplanted, there is a big problem, right? But I think there is a huge indication for that, especially for burns. Acid burns, which has happened quite a few cases. I've seen these kind of cases. Although we haven't done one yet in India, our dream is we need to collaborate together, maybe plastic and reconstructive surgeons, neurosurgeons, maxillofacial surgeons, dermatologists. All of us need to work together and form a team, including, medical and ICU specialists. A big team has to be done, and I think it's not too far before in India we start doing face transplants.
Transplant itself.
Absolutely.
It's not transforming, it's transplanting a different
transforming
face.
We are already
We are
doing
it.
That transforming is already being done. And we have grown faces. I mean, there is a condition in like when you have fused jaws, for example, in children, there's a fall and the jaw doesn't grow at all because the temporomandibular joint, the jaw joint, fuses. So the lower jaw is very much further back. It's almost at the neck level. So for these kind of cases, I've used distraction and brought the jaw forward by almost 4 to 5 centimeters, right? And we have given excellent results, and that is face transformation. People with facial deformities, which are very significant, one side underdeveloped because of certain hemifacial microsomias or any of the syndromes, again, distraction has been a game changer for her. Transferring tissues, putting in soft tissues, putting in fillers, again has, as second stage or third stage, that level of transformation is already done. But for somebody who has lost their face because of whatever reason, nasty accidents, very bad cancer, or it could be because of fungating diseases, we put prosthesis today, and which is held with implants too. But I think it's time that India also looks at face transplants.
Transplant itself.
And I would be, I would love to be a part of that team, and hopefully during my time,
You'll be there at the front end. You'll be there at the front end.
I would love to see that. And collaboration is the key. And if we bring everybody together to the table, we all bring in our expertise, and the patient is the one who gets the best.
It's the best outcome, isn't it?
Yeah.
Wonderful. Thank you so much, Dr. Girish, for that.
Pleasure, Dr. Prasad. It's awesome. A neurosurgeon from UK, and it's such an honor to have a chat
The
with
pleasure
you.
is mine. The pleasure is mine. Thanks so much.
Thank you.